Hello, friends, and welcome back to the Mama Doc Baby Doc podcast. I am Rachel, a pediatrician, and I am here with my mom, Renda, who is an OBGYN. Hey, Mom.
Hi, Rachel. And to all of our listeners out there, welcome to another episode of the podcast. Whether you're a new listener or a returning listener, as always, I'm really glad that you're spending some time with us today. We've had a little break due to Christmas, and I think this is going to be our last episode of the year of
Yep.
2024. So
Yay.
we're back recording more episodes. I'm particularly excited about today's episode because today's episode is all about cesarean births.
Yeah, it's so exciting. So, in this episode, we're going to learn about cesarean births, both planned and unplanned. No one wants an unplanned one, but they do happen.
They do happen.
I had JJ, my son, vaginally, and I know you, Mom, had all of your deliveries vaginal.
Right, right.
But whenever a woman is in labor, a C-section is always a possibility. I mean, even when I had JJ, there was a possibility, and they told me that. They said,
Right.
"You've got 3 chances to push him out. Otherwise, we've got to take you for a C-section." And I was
Ooh.
like, "Bet, I'm getting him out." We just really want to be prepared. Everyone should be prepared, no matter what
Right,
happens, either way.
right. Because whether you're planning a cesarean section or not, it's important to understand that it might happen.
Yep. Yeah. Yeah. Being prepared for the possibility of a C-section is really crucial. Sometimes it really is the right choice for you or your baby's health. It's okay to feel upset about having a C-section when you were expecting a vaginal birth,
Right,
but
right,
try not to let it overshadow like the joy of becoming a new parent or becoming,
right,
having another child. Um,
right.
if it does, don't hesitate to ask for help. So, Mom, tell us what we're going to talk about today.
All right. So, in this episode, our listeners will learn about factors that can lead to a planned cesarean section, what happens during a C section from start to finish, how the hospital might implement some enhanced recovery strategies both before and after the birth. We're going to talk about spinal anesthesia, how it works, and why it's the preferred method. Who's going to be in the operating room? Who are the people that are going to be there? We'll talk about what the surgery feels like and what a family-centered cesarean section is, and why I recommend that everybody ask for it. Right.
Yeah, exactly. So, we said that this episode is all about C-sections or cesarean births. We're going to learn about planned and unplanned cesarean births. So, why is that important?
So I want to talk about planned cesarean birth because in some ways I feel like women who are having a planned C-section are kind of left out when it comes to talking about giving birth, right? And I
Yeah.
don't think that that's intentional. I think it's just that most women have a vaginal birth, and so that's what gets discussed, right?
Yeah, even for patients who are planning a vaginal birth, it's important to listen to this episode so they can learn about an unplanned cesarean. I mean, it happens. Sometimes things don't go as planned, and if you end up needing a C section, it will be so much easier, kind of if you know what to expect, what to ask
Right.
for. It can be part of like your birth plan. Um,
Right.
Now, I know a lot of people say that if you want a vaginal birth, don't even talk about C-sections. And I don't
Right.
think that's the right thing to do.
Yeah, I disagree too. It's important that you're prepared for the possibility of a C-section. I mean, as it stands right now in our country, roughly 30% of deliveries end in a C-section. And I think that number, of course, is way too high. And fortunately, the cesarean section rate at the hospital where I practice is around 16%, which I think is much more reasonable. But
Yeah.
regardless, there are instances when a cesarean is the best option, either for a mom or for the baby. And we can't usually predict ahead of time. So you're just going to feel so much better if you have some idea of what to expect if you happen to end up needing a C-section. I mean, it's not likely. The most likely thing is that if you go in labor, you're going to have a vaginal birth, but you just want to be prepared in case. I mean, sometimes babies don't tolerate labor, and
Mhm.
sometimes no matter what we do, the baby just won't come. I mean, there's some
Yeah.
women that push for hours and hours and then end up having a cesarean to deliver the baby. And I hate when that happens, but
Yeah.
we do what we need to do to get the baby out safely. So, this episode is not going to cover the reasons for an unplanned C section. This episode is really going to be talking about what happens in a planned cesarean birth and what to expect with that. So I'm going to go over some of the reasons for a planned cesarean birth and then just the timing of that birth based on the reason. It kind of varies. And then also just kind of walk us all through what a C-section is like from the preparation ahead of time and what happens in the OR, the anesthesia part of it, and also the recovery part of a C-section.
Perfect. That sounds great. So, to all of our moms out there, the first thing I want to say is that if you do end up having a C section, it is okay. Um, it's okay to be upset about it too. We have a tendency too often within our culture, if you and your baby are okay, then you should just be thankful and happy that you and your baby are healthy. Um, don't be upset that you had a C-section. Everyone's healthy. It's fine. Well, you are allowed to be upset if that's how you feel, and that's totally normal. Um,
Right.
I I should say to be thankful that everything went well and to be upset that you had a C-section at the same time. That's
Right.
okay to
Right.
feel that. Yeah.
Right. Right. Now the issue where that comes into play is if being upset about having a C-section interferes with your ability to be a good mom, to be a new
Yeah.
mom. Now, if that's the case, then you need to ask for some help because you don't want to let that experience detract from having this beautiful new baby in front of you. And then
Yeah.
the other thing I want you to hear right up front is that if you have a cesarean section, you are not a failure. You still gave birth. You cannot be a failure when you grew a whole entire human being
Exactly.
inside of your body. There's
Mhm.
absolutely nothing about that that's a failure. The way that your baby arrives is not a reflection of your worth, not a reflection of your success or failure. It's just a reflection of how the baby came into the world. So if you had a C section, it's okay to be upset, but you're not a failure and you still gave birth.
Yeah, exactly. Okay, so let's start off talking about planned cesarean. Why do some women have planned C-sections?
Right. So the most common reason for a planned C-section is an elective repeat C-section, meaning that women who've had a prior C-section choose to have another one for their next birth. And that's obviously within their right. And usually when we do that, we're going to schedule that around 39 weeks gestation, somewhere between 39 and 40 weeks. And we do that so that most women won't go into labor beforehand. So the
Yeah.
idea is to do it when we know the baby is full term and ready to be born and there's no risk of prematurity, but yet before labor actually starts.
And 39 weeks is when studies show that babies are pretty ready. So 39
Yeah.
weeks between 39 and 40 weeks. So we want to do it when the baby's ready, but before labor has started. And babies who are born at 39 weeks do really well.
Yeah. Yeah.
Yeah.
So if you go into labor before then, because that does happen, right, Rachel? If you do
Yes,
go into labor before
unfortunately.
39 weeks, then we just do the C section when you come in labor. And if you've had a prior cesarean section, you can elect to have a repeat section for your next birth. Now, I want to say something about vaginal birth after cesarean or VBACs, right? If you have had one or even two prior cesarean sections, and as long as they were the right type of incision on the uterus, and it's what we call a low transverse, and it's the uterine incision, not the incision on your belly, that's important. As long as you've had that right type of incision, then it's entirely appropriate to try for a vaginal birth for your delivery. But there are some hospitals and some physicians who don't support VBAC deliveries, and patients then are essentially forced into a repeat cesarean section. If that's the case, I want you to know that you can choose to go somewhere else to deliver, find a different doctor or hospital, or you can, if you choose, simply have a repeat cesarean section. There's nothing wrong with that either.
Yeah, I know, especially in some of the rural hospitals that I have worked in or John has worked in, they just don't have the support to do VBACs at
Right,
some of them. Like, you really want to have a team there just in case something happens.
right,
And I know, especially at some of the hospitals that John's worked at, they just didn't do them because they didn't have the right support there to just in
right.
case something happened. So yeah, pick a different hospital if that is something that's important to you. Another common reason for C-sections is breech presentation.
Right,
Breech is when
right,
the baby is upside down, head is up and butt is down,
right, right,
essentially.
right,
um,
right,
Either the butt
right,
or the feet are first. And
right.
that's pretty common too, unfortunately.
Right. And those C-sections are typically going to be done between 39 and 40 weeks also. So 39 weeks when we know the baby is ready, but before labor starts. Now, if you have a breech baby and you're approaching full term, there are some things you can do to help encourage the baby to turn. There's an online website called Spinning Babies that you can check out for tips. Some people try acupuncture. Your doctor may offer a version procedure where we attempt to turn the baby by pushing on mom's belly and lifting and coaxing the baby to turn. And this works sometimes. But sometimes, despite all of our efforts, the baby remains breech. And at this point, we do not recommend breech vaginal deliveries. There's just really a significantly high risk for head entrapment and injury to the baby during the birth. And that risk is just too high. So we don't typically do breech vaginal deliveries except for rare circumstances. So if your baby's breech, your physician or midwife is more than likely going to recommend a C-section delivery for you.
Yeah, I actually had a patient who was born vaginally breech, but I only have seen it the one time. She actually was going to a midwife, and the midwife told her, "You're going to have to go see a physician in a hospital." So she did end up having the baby in the hospital, but she had it vaginally. So,
Yeah.
um, but I don't know. It sounds scary.
Yeah. Yeah.
You also do C-section deliveries often for multiple gestation pregnancies, like twins and triplets.
Yeah, definitely. Now for multiples, and this is typically, I'm speaking of twins here, typically, triplets are almost always going to be born early. They just come
Mhm.
early.
Yeah.
But twins, we generally schedule that no later than 38 weeks if you have a cesarean for twins. They also usually come a little early. So you don't necessarily have to have a C-section for twins. If both of the heads are down, you should at least be offered the opportunity to have a vaginal birth. If
Mhm.
one head is down, the first one is down, and the second one is not, then a lot of doctors are still going to offer a vaginal birth, depending on the position of the baby, though some won't. If both babies are breech, then pretty much all doctors are going to recommend a C-section birth as the safest mode of delivery. But generally, if you have twins, it's going to be scheduled at about 38 weeks, not usually later than that.
Yeah, and I've seen all those combos for twin
Yeah,
deliveries, like both born vaginally, one like the first one vaginally, and then the second one they transition to
right,
do a C-section. So, but twins almost never make it full term.
right.
The placentas age faster with twins, so
Yeah.
38 weeks is really considered full term for twins. So you can expect if you're going to have a planned C-section for twins that they're going to schedule it no later than 38 weeks.
Right. And the next reason for a planned cesarean birth is an indicated repeat C section, meaning that because of your prior history, then having a repeat C section is appropriate. So that would be, for example, if you've had 3 or more prior C sections, then pretty much no one is going to offer a trial of labor after cesarean because the risk of uterine rupture is considered just unacceptably high. So that's going to be between 39 and 40 weeks when we schedule that. Another indicated repeat cesarean is if you have had a prior uterine rupture. That's going to be done generally 36 to 37 weeks. because uterine ruptures are devastating, and we really don't want you to have contractions. We don't want you to go into labor at all if you've had a prior rupture. That old incision just does not need to be stressed. So if you've had a prior classical incision, that's an up and down incision on your uterus. And I'm not talking about the incision on your skin, it's the incision inside on your uterus. So it's not something you can see from the outside. We have to look at your operative note, the operative report that the surgeon dictated after their surgery. And if you've had a prior classical C-section, then we're going to recommend that all of your future births will be by C-section. That would be an indicated repeat. And again, we do those between 36 and 37 weeks also.
That's good to know. There are some other conditions when a planned C-section is appropriate. One is placenta previa.
Right.
I've been a part of a couple of those C-sections. Can you talk about that?
Yeah. So placenta previa is when the placenta covers the opening to the cervix. And that can cause extreme bleeding and even life-threatening bleeding for mom and for baby. The placenta is where all the oxygen and nutrients are exchanged and for blood flow between mom and baby. And if the placenta is covering the cervix, when the cervix starts to open, that placenta is sitting right there. So a lot of blood comes out really quickly. And it doesn't take that much blood to be lost for your baby to become anemic. So placenta previa is a situation where if you have that, we're definitely going to want to do that indicated C-section early. And that's generally scheduled 36 to 37 weeks. We don't want you to start to have cervical dilation. And we really don't want you to have contractions at all. And then another indicated reason for a planned cesarean is that maybe a woman has had a prior myomectomy, and that's where a fibroid is removed from the uterus. Depending on where the fibroids are, if the fibroids were in what's called the contractile portion of the uterus, the part of the uterus that does the squeezing, if the fibroids were removed from that part of the uterus, then we're going to recommend a C-section, because those old incisions, those scars that where we took the fibroids out and then put the uterus back together, they're just never as strong as the uterine muscle. And there's a very high risk that with the stress of contractions, those old scars from where the fibroids were removed could open up and cause a uterine rupture. So it's appropriate, depending on the type of fibroids you've had removed, that you might need to have a C-section for delivery. And that's also can be done. It depends on the size and how many and how big they were, but somewhere between 37 and 39 weeks. If it was full thickness all the way through the uterine muscle, and also the location is really important for determining when we need to do that C-section.
Gotcha. Okay, I do know that some women choose to have a C-section just because that's what they want.
Right.
Especially in other countries, women will have elective C-sections, even for their first baby, because they choose to do that. Some say they want to protect their pelvic floor, and others just don't want to go through labor at all. Can
Yeah,
you talk about
absolutely.
that?
Yeah, there is a small subset of women who choose an elective cesarean section. They don't want to go through labor. And I always counsel those women and make sure it's their choice. Sometimes it's for wanting to preserve their pelvic floor, not have prolapse issues. Sometimes it's for a history of trauma, that going through a birth would be a very traumatic experience for them. And if that is what a woman wants, if they want to do a primary cesarean section, then yeah, we do that. It's an elective primary C-section, and it's completely the patient's choice, as long as they've been informed and know the risks and benefits of both types of deliveries. We usually do that one between 39 and 40 weeks also.
Yeah. And, I have to admit, I can sort of see what they're saying about protecting their pelvic floor and not wanting to go through labor. If you've not been through it, like it's so scary to think about it. But I, you know, having been through medical school and being a physician, I've seen lots of surgeries, and I would never ever choose to have a surgery over doing something safer like a vaginal birth.
Right,
So I sort of don't understand, but at the same point, I
right,
do understand. Is it
right.
really appropriate though to choose
Well,
to have a surgery?
yeah, so we do know that vaginal births are safer, but as long as people have the information, as long as they're informed about the risks, the benefits, and then yeah, they can choose. Vaginal birth is not without risk also. Both of them
Mhm.
have risk. It's just that vaginal birth is generally safer for moms and babies, actually. But that doesn't mean it's a vaginal birth is completely without risk. So as long as you know the risks and the benefits of both approaches, if you choose to have a C-section, then that's your choice. Benefits
Wow.
of the cesarean section are that it does protect the pelvic floor from damage. It decreases the risk of urinary incontinence later,
Yeah.
and other types of prolapse. Right.
Yeah, and it is your choice, and I agree that if that's what you choose, you should be supported to do that. Um, so, just summarizing a little bit, the reasons for a planned cesarean are if you have had a prior C-section, if your baby's breech, if you have multiples, if you had a prior classical cesarean section or prior uterine rupture, a history of fibroids that have been removed, or if you have placenta previa, or if you just choose to have one done.
Right.
Right?
Exactly. Yeah.
Yeah.
And one thing I want patients to keep in mind is that they may not happen exactly when planned. If you have a planned C-section, it may not happen exactly when you have planned. I've seen people get a little bit thrown off by this. Now, most of the time it does, but it's certainly possible that your planned C-section might not go when you plan for it to go. Your water could break. You could go into labor early. And in that case, the C-section is going to be done when you come into the hospital in labor. Sometimes there are scheduling conflicts. There's an emergency surgery that bumps your C-section. So it may not exactly be your doctor also. If you come in labor, it may not be the doctor that you've chosen. It's going to be whoever's on call. So just keep that little nugget in the back of your mind that your planned cesarean may not happen exactly when planned, because just like with all birth, the only thing that's predictable is that it is unpredictable. Right?
And it doesn't matter how many times you hear that. The
Yeah.
second they tell you, oh, you're going into labor today instead of next week when you thought, you will still
Right.
be wrecked. You will
Yeah.
still cry. It will be awful. But try to remember that it's unpredictable.
Right.
Okay, so let's talk about what to expect with an actual cesarean birth. Um, Walk us through like the whole procedure. So when it's planned and we know it's going to happen, then we do something called pre-admission testing. That happens first, right?
Right. And what happens with that is you will get blood work done to make sure that you're not anemic. We get your blood type done so that if you need a blood transfusion, although that's not likely, we like to have blood available and ready. You often have to leave a urine sample to check for infection. You'll meet with your surgeon and she'll go over the procedure in detail with you and explain it and answer your questions. Some people meet with the anesthesia provider, but generally that's only the ones that are higher risk.
Yeah. Okay, so talk to me, and this is a huge controversial topic, but talk to me about eating and drinking prior to
Right.
surgery.
Right. So recently we have started something called ERAS, ERAS, and that has nothing to do with Taylor Swift. Okay. It's something called ERAS that stands for Enhanced Recovery After Surgery. And there are some things that you can do beforehand to enhance your recovery after surgery. So one of those is carb loading, like with Gatorade, actually. So some hospitals may do that. We ask our patients to avoid solid foods for 8 hours prior to surgery, but to keep drinking clear liquids like Gatorade or apple juice up to 2 hours prior to their scheduled surgery time.
That is so much better.
Yeah.
Um, if you're not dehydrated and hypoglycemic, imagine that you might do better after surgery.
Right, exactly. That took us a while, but we finally figured that out. Now, on the day of the C-section, you're going to be asked to arrive a couple of hours in advance. You're going to get an IV. You may be asked on that day to do special wipes. If you didn't meet with the anesthesiologist or the nurse anesthetist beforehand, you're going to meet with them that day. Or if you did meet with them before, you're going to meet with them again that day. They're going to go over the risks of anesthesia. Now, most often we want you to be awake during the surgery with a spinal anesthesia because number one, that's the safest anesthesia. But we also want you to be awake so that you can enjoy the birth of your baby and you can see your
Yeah.
baby. Now, it could be that you have to have general anesthesia for some reason. That's not as likely. And I'll talk about that in a little bit. Most often, they're going to talk to you about a spinal anesthesia. So once everything is ready, you got your blood work done, the IV's in, all that's done. You'll meet with your surgeon beforehand. Your doctor's going to come in and talk to you. You'll sign a bunch of consent forms. Then we go back to the operating room.
Okay, I have a quick question. You said you
Yeah.
may be asked on that day to do special wipes again. What does that mean?
Yeah. So some doctors give like antibacterial wipes that they ask people to wipe themselves with, or a special
Mm,
shower that they need to take beforehand to be clean. It's to limit bacterial infection.
gotcha.
Yeah,
Over
not
your
everybody
body.
does that. Over your body, your belly, particularly where they're going to make the
Gotcha.
incision. Yeah,
Okay, gotcha. Okay, so we were talking about you're going to go back into the operating room. Most of the time, you're going to go back by yourself initially
right.
into the operating room. Your partner, your husband, your spouse, your baby daddy, mommy person doesn't come back with you. Or sometimes it's a grandma, or I've
Right,
seen an auntie or a friend.
right,
Whoever your
right.
support person is, they don't come back with you until later. And if they do want to come back with you, then usually they are asked to wait outside the operating room until the spinal's placed.
Right. And once the spinal is placed, and I'm going to talk about how that goes in just a second, then your partner or your support person will be able to come into the OR and be with you. Usually it is just one person that can be with you in the OR, and that's really due to space constraints. We want
Yeah.
someone there with you, but there's just really not a lot of room up by your head, and your anesthesia provider needs to have room to do their job, which is to monitor
Mhm.
you throughout surgery and make sure that you're okay. Now, once you get to the OR, you're going to get the spinal. And the spinal is a single injection of medicine that's going to numb you from a certain level on your abdomen down. Um, it's different from an epidural. With an epidural, a catheter is placed in the epidural space, and you get a continuous infusion of medication through the epidural, and it lasts during your labor. But for a C section, a planned C section anyway, a spinal injection is appropriate, and that's a single injection. It's going to last 2 to 3 hours to help you not feel pain, and it works really, really well. There's no reason to put that catheter in because we don't need to keep using it. The C-section will be done within a couple of hours. So you most likely going to get a spinal for a planned C-section, not an epidural.
Yeah, people get confused about these because, the difference between an epidural and a spinal because they go in
Right,
a similar place. There's a needle initially going into your back with both, but
right,
with the epidural, a catheter, a little thin plastic tube, is left in there, whereas the spinal is not.
right,
Now, getting a spinal is not very painful. Just a quick pinch to numb the area, and it doesn't take too long. It can take longer if your anatomy is different. For example, if you have scoliosis, if your spine curves, it can take a little bit longer to place a spinal. And also, I'm going to be honest, it can take a little bit longer if you have extra weight, like if you're a little bit bigger or heavier. If you can feel your bones of your spine very easily on your back, that makes it a little bit easier. Whereas if you have a little bit of extra fluff or even muscle in that area, it can make it harder to find the right space to
right,
go. The
right,
anesthesiologist or CRNA, whoever's doing your anesthesia, has to be able to feel it in order to know where to kind of insert the needle. And if your anatomy is different, there's a lot of extra fat tissue there. It can be harder to feel the bones. So it can take a little bit longer.
right. Now, I've seen the spinal take 30 or even 45 minutes with multiple attempts at
Mhm.
getting it placed. And I'm not trying to offend anyone or upset anyone. I just want to convey a true picture of what can happen, that it can really be challenging because you have to be able to feel those bones in order to know where you're putting the needle, right?
Yeah.
And that's actually the same for an epidural. When an epidural is being placed, it can also take longer if you're really short and your bones are compact or close together. If you have extra weight, if you have scoliosis or some other issue with your spine, that can make it really difficult to feel the bones and get in the right space.
Yeah.
Okay, now The rest of what I'm going to describe is what happens whether or not it's a planned C-section or an unplanned C-section, okay? Whether it's planned or unplanned, the rest of it is pretty much the same. If it's unplanned and you already have an epidural, then what we do is we just give you a really big dose of medicine through that epidural, and that's going to work for you during your surgery. If it's unplanned, then you don't have an epidural, then you're more than likely going to get a spinal.
Yeah. All right. So once you get into the OR, whether it's planned or unplanned, and you have the spinal or an epidural, then you get laid down on the operating table. So talk about that.
Yeah, that can feel a little bit awkward because your arms are stretched out to your side. You're in like a T position on the OR table. And you'll start to feel the numbing medicine kick in pretty quickly, where you can kind of know where your body is. You know it's there, but you can't really feel it. You can't really feel what things are happening, and people are moving your legs, and you can't really tell. And it just feels really strange.
Yeah. And they strap your arms down too, which can be strange.
Yeah. So you absolutely don't have to have your arms strapped down. We use little straps with Velcro, so you can, and we keep them really super loose, so you
Yeah.
can definitely get out of it. You're not really tied down. But it's just there as a reminder not to touch your belly because your belly is going to be washed with surgical prep. Now,
Mhm.
if it really bothers you, you can ask them to unstrap your arms because they can be loose. There's no reason they have to be tied down. We leave them very loose, and really we leave them there as a reminder not to reach down to the operative field. Now, I have to say, this is really funny. I stand right next to the patient, right at their side, right under their arm. So when the drape is up, they can't see me. So they don't know for sure where I am. And they often start to reach down, and the first thing they touch is my butt. So I
Yeah.
have had many patients rub my butt during their surgery, and it is a little bit distracting. So I usually do say something when that happens.
We're just giving you some love pats, okay?
Yeah,
Just
I
a
know.
good game.
Yeah. Yeah.
Yeah, I think that would for sure be distracting. Um,
Yeah.
but now, once the patient is laid down, the nurse
Yeah.
is going to shave your pubic hair if you have any hair down there, or if there's any hair where the incision is going to be made.
Right.
It decreases the risk of infection. They're not going to shave like vaginal hair, right? Just
No,
around
just
the incision. Yeah, anywhere
right.
around the incision.
Right. And sometimes we do that in the operating room, and sometimes we do that in the labor room prior to coming back to the operating room. And we actually use clippers, not a razor. So the hair is being clipped, not really shaved. And I want patients to hear me on this. Do not shave ahead of time because, oddly enough, that can actually increase the risk of infection if you have shaved within a few days prior to surgery. There can be little microscopic cuts in the skin that increase your risk for infection.
Mm. So I don't feel like, oh, I'm going to shave or I have to shave just in case in order, if I have a C-section, it can actually increase your risk for infection. That's good to know.
Right, right. Now you can clip your hair if you wanna do that to make it, away, but just don't
Shorter.
shave.
Yeah.
Um, and that's what we do. We actually clip. So it's clippers, not shaving. And clippers can help decrease the risk of infection. If we shave, like with a razor, that increases the risk of infection. So the nurse that clips you is going to use clippers to get the hair out of the way for where the incision in. Now, the incision is going to be down really low. It's a low transverse incision on the skin almost always. And that's like we call it, some people call it a bikini cut, very low. Um, Now, in addition to clipping the hair, we're going to put a catheter in your bladder so that your bladder can be emptied during the surgery. You know, your bladder sits right on top of the uterus, down low. And we want it to be empty and out of the way so that we don't accidentally cut it or nick it during the course of getting your baby out. You know, they're very, very close together.
Yeah, and then something called sequential compression devices we put on your
Yeah.
calves in order to prevent DVTs or deep vein thrombosis. These are little cuffs that are going to squeeze your legs, and they do it in a sequential way, and it helps prevent blood clots. So you get those on you, and you'll keep those until you're up and walking after surgery.
Right. And again, you won't feel most of this. You're not going to feel the clipping. You're not going to feel the catheter, and you should not feel the SCDs being put on. If you do, then
Yeah.
that could be a sign that your spinal or your anesthesia may not be working well. All right. Now, then the nurse is going to scrub your belly with the surgical soap that helps prevent infection. And once the soap is dry, typically that takes about 3 minutes, then we put the surgical drape on. When they're washing your belly, you're going to feel it. It's really hard to explain what it feels like, but you know something's happening, but it's just it feels a little odd. And for example, the scrub that they use is wet and it's actually cold, but it's not going to feel cold. You'll just know that something has happened. A couple more things that are going to happen is that you're going to get an antibiotic, at least one, sometimes more, through your IV, and that's to help prevent infection. There's going to be a timeout where everyone in the room stops. We confirm who you are, your name, why you're having the surgery, your date of birth, what surgery you're having done, if you have any allergies, and that you received the antibiotics.
Yeah, timeouts are really routine to make sure there's no mistakes. It's going to sound crazy because we're going to ask you, hey,
Mhm.
can you tell us your name and date of birth? And you're like, do you guys not know who I am?
Right,
But it's really just so that we can match it against your name tag being, making sure we have all of the things correct and labeled and
right,
that you can hear that we're saying the right things that are going to be done. So everyone's on the
right,
same page, no one's confused, and we
right,
all know
right.
what we're doing.
Right. Now, before we start, we actually test to make sure that the anesthesia is working. And we do that with a surgical clamp. We have this tool that has very sharp edges, very sharp. So if your anesthesia is not working well, it's going to feel like a sharp pinch.
Mhm.
Now, what we should say is, do you feel me pinching you? Sometimes people clamp and they don't say anything. They're waiting for you to react. So if they pinch you and you feel something and they're not saying anything, if it feels painful, you need to speak up and say, hey, that hurt, that pinched, and that felt painful, so that we
Yeah.
know that your anesthesia is not working. And it should not feel painful. I can't reiterate that enough. You should not be experiencing pain during your C-section. Now, you will feel touch. You will feel pressure. And sometimes it can be quite a bit of pressure, especially when we're pushing the baby out, right? But it should never be really painful or sharp.
Yeah, and before too, I've heard some people give the anesthesiologist or CRNA kind of like a code word so that they can watch the patient's reaction really closely too. I think it was like
Right.
Lady S. I don't remember some code word while they were pinching the patient. So,
Yeah.
and then the anesthesia provider would be like, no, she's not feeling that because they can tell by
Yeah.
your reaction, hey, she's
Right.
not acting like that's painful, but it really should not be painful.
Right.
If it feels painful, please, please, please speak up. Please speak up. Um, Now, I'll say the alternative. If your spinal is not working or your epidural is not working, then the alternative may be that you have to go to sleep under general anesthesia for the surgery. If you have
Right.
to go to sleep for the surgery, then that's the best option for pain management. Then that's the best option. That's what has to
Right.
happen.
Right. And of course, we try to avoid that. But if your anesthesia is not working, you may need to go to sleep for the surgery. So now let's talk about who is in the room during a C-section. There are going to be at least two nurses. One is what is called a circulating nurse, and she's there to grab extra things for me if I need it. She's there to count the instruments, to count the sponges, make sure that everything is functioning well in the OR, and that we have the things that we need. Okay.
Yeah. And then there's going to be a second nurse who's there for the baby. When the baby is born, they'll be responsible for assessing the baby, taking care of the baby, getting the baby back over to mom. Sometimes it's a pediatrician, sometimes it's a midwife for who is in the room for the nurse to help with the baby. This is more likely like a pediatrician or another provider is more likely to be there when we're concerned that there is a possible problem with the baby, or if there's been a labor complication and the baby wasn't tolerating the
Right.
labor well.
Right.
And that's the reason why we were doing the C-section. In those instances, we may also have a respiratory therapist, an RT, and an entire team ready to care for the baby. Um, I will say too, some hospitals automatically do everything if you're having a
Right.
C-section. Kind of
Right.
where I was trained at the University of Kentucky, every C-section, we had a full team of people there, no matter why the C-section was being called, even if it was just a repeat C-section. So don't be freaked out if they have a
Right.
whole team of people there for you. It might just be that that's their protocol at that hospital. But I feel like most hospitals, it's just if they're worried there's an issue.
Right.
And
Right.
if there is a concern about your baby, then there may be a NICU team there, a team from the neonatal ICU. That's generally going to be 3 people: a neonatal nurse practitioner, a respiratory therapist, and a NICU nurse who is going to be there. Um, and yeah, so like I said, though, some hospitals, the whole team is there no matter what. But for
Right.
a typical planned cesarean in most hospitals, there's usually just one nurse there to assess the baby when it's born.
Right. So let's talk about the other people in the room too. There is going to be an anesthesiologist or a certified registered nurse anesthetist or CRNA. Oftentimes, the anesthesia provider or maybe an anesthesiologist will start the case. And then the CRNA will stay with you and finish the case. In our hospital, CRNAs do the entire case. They start it and they do everything. Of course, the surgeon is there, me.
Of course.
No surgeon can operate alone. We have to have an assistant. So there's going to be someone standing across the table from me. And I said me like I'm going to be doing your C-section. Most likely I'm not, um, but some surgeon is. And an assistant surgeon is going to be standing across from your surgeon. Sometimes that's a nurse, sometimes it's a midwife, sometimes it's another doctor. Also, there's going to be another person in the room who hands the instruments to your surgeons. That's a scrub nurse or a scrub tech. I'm telling you all this to say that there are going to be quite a few people in that
Yeah.
operating room, and that does not necessarily mean that anything is wrong. Those are the people who need to be there in order to take care of all the things that need to be done.
Yeah, exactly. So also let's talk for a minute about what's called natural or family centered or gentle cesarean. This has started as an approach to improve the birth experience for people having uncomplicated C-sections. And it's really trying to replicate as much as we can about a vaginal birth and make the C-section more family friendly. And, these are all fairly easy things to implement. Some hospitals implement this routinely, honestly, at most C-sections.
Right, right. But for some hospitals, you still have to ask. Some parts
Mhm.
of a family centered or gentle cesarean are really simple and easy. For example, having music playing in the background, and that should be music of the patient's choice, of your choice. And we do that all the time, whether the mom chooses it or if she doesn't have a particular choice, then I have a playlist that I like that's relaxing and fun. We also try to dim the lights a little bit, and we can definitely do that safely. It's a possibility just to make it not quite so bright in the
Yeah.
operating room. Okay.
Yeah.
Yeah,
OR lights are so, so bright.
they are. They're definitely bright. And there are options for dimming the lights in the room, but we still have our surgical lights so that we can see. And then we try to reduce extraneous noises, not so much chit chat to make the room more calm and peaceful. Some hospitals use clear drapes so that the mom and her partner or support person can actually watch the birth. Um, and we have that in my hospital, and I really like that because I can see the patient during the C-section, which is kind of fun also. And it's not really gross because the belly's there. So the incision's on the other side of the belly, below
Yeah.
the belly. So she can't
Yeah.
really see the incision and see her belly open. But what she sees is the baby coming
The
out from
baby.
behind her belly, and she sees
Yeah.
the baby, right?
Yeah.
Um, Now, we try to use sedation so that mom is completely awake. So the anesthesia providers, they avoid using sedating medications if they can. We don't want you to be knocked out during your surgery. We want you to be awake. And we
Yeah.
also want to keep your hands free so that you can hold the baby, right?
Yeah.
Yeah.
Yeah, you can keep your hands free so you can hold the baby in the OR if need be. And then the final thing is we do skin to skin contact as soon as possible in the OR. The nurse
Right.
brings the baby over to do skin to skin contact in the OR. It can be a little bit awkward because you're laying there, it's just kind of awkward,
Yeah.
but it's really nice and sweet.
Right. And good for baby. Yeah. And we
Yeah.
also do delayed cord clamping at the time of a C-section. That's recommended for at least 30 seconds. I always try to do between 1 and 2 minutes. We can leave the cord as long as pulsating as long as baby is fine. Then I also leave the cord long because dad does not get to cut the cord in a
Yeah.
C-section. It's a sterile field. We can't break sterile field. But if I leave it long, then dad can trim the cord later and he gets the sensation of cutting the cord because he gets to
Yeah.
trim it.
Yeah, where when I worked in the hospital and saw all the C-section babies afterward, it was really cool to, you know, give the dad the scissors and say, "Here, cut the cord. Do you want to cut it?" Some dads would be like, "No, thanks. I'm good."
Yeah. Yeah. Yeah.
But I do think most dads really like to do that. They
Right.
like to feel involved. A lot of times they can feel really helpless in the delivery room or the operating room. So it's important to talk to your partner about these things too. Um, get your partner to listen to the podcast too, so they know kind of what to expect and how to better support you and help you. Definitely in the prenatal period, you should ask about what cesarean birth looks like in the hospital. You should have this as sort of a plan, your backup plan for if you have a C section, how things are going to go. That way you're prepared just in case. So you want to ask things in your third trimester like, hey, can I have music in the
Right.
operating room? So if you end up having a C-section, whether that's planned or unplanned, be prepared for it and ask your provider if you can do the family centered um, things for that. And you want to be really clear with them. You don't want a C-section.
Right.
You just want to
Right.
be prepared for the possibility. So if that happens, can you have music playing if that's something that's important to you? Or does the hospital have a clear drape?
Right.
Do they do delayed cord clamping, skin to skin? Tell the surgeon you want to see your baby as soon as possible. That's the moment you definitely are going to remember.
Right. I know when we first hold the baby up over the drape, even when the patients choose the blue drape that they can't see through, we put it down and lift the baby up so mom can see the baby right away. And they're purple and they're wet and crying. And most people snap a photo of that, right? Those are the moments that they're going to remember. And then also ask your provider, your surgeon, who's allowed to be in the room with you. Also, during the C-section, after your baby's born, if you haven't seen your baby for a minute or they haven't been brought over to you, don't be afraid to say, hey, when am I going to see my baby? Right. Or I'd like to see my baby as soon as possible. Or have your partner ask, because sometimes the people that are taking care of your baby, they just get caught up in it, right? Like we got to wrap up the baby, or we got to do this, or we got to do that. And I don't think it's intentional, but they just get caught up in their job, right?
Yeah, I agree. I don't think it's intentional. They just don't necessarily realize the importance of prioritizing and doing that as soon as possible. They have a
Right.
job to do, they're doing their job. And I know most hospitals try to prioritize this. It's funny, when I was in residency, I was in my final year, my third year, and I had an intern with me. An intern's a first year, so a very baby doctor. um,
Yeah.
and he did not realize this, and was not prioritizing mom. And he was trying to teach a med student about examining a baby right after delivery. And I had to tell him, hey, we need to do this later. You need to get the baby to the mom now.
Right. Right.
So it's not
Exactly.
intentional. And that, he did not realize it, but he was just
Yeah.
not thinking. Um,
Right.
so ask.
Mhm.
So that's the whole point, is ask, because people just might not be thinking in the moment. But
Right.
most hospitals prioritize this. And moms can always sneak up and ask if you or speak up, sorry, not sneak up, speak up and ask if you want your baby sooner. And you might be in the OR for quite a bit of time. And, the answer might be, hey, they're working on baby. They're going to bring the baby to you as soon as they can. And even sometimes the support person can go over and stand next to baby and take pictures for you. But they, if you're not getting your baby as soon as you want, just ask. And even if the
Just
answer's,
ask.
yeah, we're trying, they'll get it to you eventually.
Yeah, yeah. It's good. It's a good reminder. And
Mhm.
you're right. The C-section itself can take quite a bit of time. So you're going to be in that OR for a little while. Once the baby's out, we're not done. We still have a lot of work to do. So C-section on a minimum is 30 minutes, but usually it's more like 1 to 2 hours. A 30-minute to an hour is a very quick, straightforward C-section. 1 to 2 hours or longer if there's scar tissue, if there's any
Mhm.
bleeding that needs to be stopped. So I would say plan for an hour and a half on average. Every now and again, I have someone ask me, how much longer? How much longer? And I have to be honest, that question used to annoy me. Like, I'm going to take my time. It takes as long as it takes. I'm sewing you back together and I'm not going to rush this, right? Um,
Yeah.
I'm operating. I'm not like playing around. And you don't want me to rush. But then I had somebody say that it wasn't that she was just wondering or that she was upset that it was taking too long, that she was just very anxious about it. And it helped her to cope with how being there, just knowing how much longer it was going to take. So it wasn't that she was upset or there was a problem or that she was worried. It was just that she was very anxious and it helped her to understand what to anticipate. So that was something that I learned. And I'm not offended by it anymore when
Yeah.
people say how much longer.
Yeah. So you can ask your doctor how much longer
Yeah.
will it take. If they don't answer, tell your surgeon I have anxiety and I just would like kind of a plan in my head of how much longer this is going to take so I can understand it a bit better. Um, I just want to know kind of what to expect. Yeah. So
Yeah.
let's talk about recovery.
Okay. Yeah. Recovery. So after the surgery is done, then all the drapes are removed. The nurses and the OR staff are going to move you over to a bed. The surgeon generally leaves right away when we're done with our part because we have a bunch of paperwork we have to do. And then the nurses and staff are the ones that do that moving kind of thing. You're not going to be able to move by yourself. Your legs are still numb. You can't move them. So they have to move you. Then they're going to take you back to generally to a recovery room. Now, the recovery room may be in a separate recovery area, or sometimes it could be your labor room. It just depends on the hospital. And you'll stay there for about half an hour to up to 2 hours that you're in recovery. And we wait for the numbing medicine to wear off. Now, I want to say this. Ideally, your baby should be with you during that time.
Mhm.
Ideally. That doesn't happen everywhere. Some places, the recovery room is a shared room where there are other people recovering from other surgeries, and we can't generally bring babies in there because of the risk to the baby for infection, but also just because there's so much going on. The nurse taking care of you can't also be responsible for your baby. But ideally, your baby should be with you the entire time. If not, then we want to get you to your baby as soon as possible. After the recovery room, you go to a regular postpartum room. And in some hospitals, that's also the same as your labor room. Some hospitals, it's one room for everything. Yeah.
Yeah, every hospital I have ever worked with or been a part of, your baby is with you in the recovery room.
Yeah.
Um,
Yeah.
and, as the pediatrician, I'm always wondering where the baby is and looking for
Yeah.
the baby. And
Yeah.
I've
There's
tried
a
to go
baby.
see the baby, and a lot of times they're in recovery, and I just give them that time. But
Yeah.
these days, more and more hospitals are doing those enhanced recovery after surgery things, the ERAS things that you talked about. Um,
Right.
and there are some things that are done afterward in order to speed up recovery, make recovery a better experience for people. So, some things that can happen or that happen with the ERAS, the enhanced recovery after surgery, that should happen. You get a long acting anesthetic medication through your spinal or through your epidural. What's it called? It starts with a D.
Duramorph.
Duramorph.
Duramorph. So like
Okay.
Dura. like long duration morphine. Yeah, Duramorph.
Okay. And it lasts for about 24 hours. So it helps with those first 24 hours with your pain control.
Right. We also give IV Tylenol and IV anti-inflammatory medicines like an IV version of ibuprofen, which can help with pain
Mhm.
relief. During the surgery, I also often place what's called a pain ball, which consists of two little catheters that are left in place. One is draped over the uterine incision and one just under the skin incision. And these catheters are like soaker hoses. They're little fenestrated catheters. So they drip ropivacaine, which is a long-acting numbing medication that keep those areas numb and help with pain control post-op. That lasts 3 to 5 days, depending on how much medication you use. But it's really nice because people get up and move around much quicker. Once you're on oral pain medication, then we typically do scheduled ibuprofen and acetaminophen. That's Motrin and Tylenol, scheduled doses. So you should be getting those anywhere from every 4 to 8 hours, depending on the doses. But they should be scheduled, meaning you get it whether or not you're hurting for the first 48 hours. And that really helps limit the need for narcotic medication. But if you have breakthrough pain, you can definitely ask for pain medicine. Some places will use IV Toradol in place of ibuprofen. That's what we do at our hospital. But it's an anti-inflammatory medication and Tylenol. Um, yeah,
Yeah, and really there's some synergy between Motrin and Tylenol, meaning that like
yeah,
they work really well together. And if you do it scheduled, like every 4 to 6 hours you are taking Tylenol, Motrin, it really helps with recovery for any
right,
type of pain. Um, and pain's kind of one of those things that is hard if you get behind on Tylenol and Motrin. It can sneak up on you quick. So
right,
really make sure you're getting that Tylenol and Motrin scheduled. They actually do a really good job together with helping with pain. But and
right,
it's really important to limit the use of narcotics. Addiction's a huge thing.
right,
It takes a couple exposures, and you really don't want to expose yourself to that. It reduces the risk of you being sleepy too if you don't take
right,
narcotics. Tylenol and Motrin don't usually make people sleepy,
right,
and you don't want to be sleepy during this like amazing time in your life.
right,
And it reduces the amount in your breast milk too. So,
right,
um,
right.
you can still breastfeed while taking pain medication, but you'd rather not if you don't have to.
Right. So, of course, we want to limit the use of narcotics. We want you to get up. We want you moving around as soon as
Yeah.
possible. Generally, within 12 hours of surgery, we want you up and moving. We try to disconnect you from things. And by disconnect, I mean we remove the catheter in your bladder. So you have to get up to go to the bathroom. We try to remove the IV so that you're up and moving around because motion is really going to help with the recovery. And you can also generally eat right away after surgery.
Yeah, it's so great. You don't have to be like on a liquid diet or anything like that. But I mean, use common sense. You don't want to just like scarf down a huge Jimmy John's sub and a thing of
Right.
sushi
Right,
right
right.
after
So
surgery.
right. Eat a little bit, then try a little bit more, then
Yeah.
try a little bit more, but you definitely can eat right away. And then depending on how your skin is closed, you may have sutures that don't need to come out. They just absorb on their own. Some places put absorbable staples in, which also absorb on their own. Or you might have metal staples that have to be removed later. But most people will have that low transverse incision on both the skin and the uterus.
Yep, that's the bikini cut. Again, you
Yeah,
can't tell about the one on the uterus, the incision on your uterus without asking, but most of the time it's going to be that same bikini cut.
right.
And you can shower pretty quickly afterwards. Also, once you're kind of up and moving around, I think once your
Yeah,
nurses are comfortable with how you get up and walk around, they're not
right.
worried you're going to fall.
Right,
They'll let you
right.
shower.
So usually that's within the first 24 hours. We really just want you to try to get back as close to your normal self as you can. Now, recovery for everyone varies. Some people have a hard time recovering from a C section. I'm going to be honest, it can be very challenging for some people, but
Yeah.
some people pop up and bounce back very quickly where they feel close to themselves within just a few days. Some people don't need narcotics after a couple days. They really feel like themselves. It's just really going to depend. I can't say that there's anything that necessarily predicts how well you're going to recover either. You're just going to have to see how it goes. And then when you're at home, you generally are going to want to limit lifting to nothing that's heavier than the baby for about 6 weeks as best you can. Yeah.
Yeah, and that can be really hard, especially if you have other children. They're going to be heavier than your new baby.
Right.
Um, and they're going to want to be picked up too. But,
Yep.
you can kind of ask them to come sit with you instead of picking them up. And or you could have other people pick them up for you.
Yeah.
Hopefully you have a big support system who can help you. I mean, it's a major surgery. It's a huge thing. Um, so, do the best you can with not lifting
Yeah,
after.
and it's important that you heal.
Yeah.
Yeah, you've gotta heal. And then, driving. When people always ask, "When can I drive?" So I always tell them, "When you can turn and look back over your shoulder comfortably, and when you can slam on the brakes without hesitating in an emergency." Also, you have to be off all narcotic medicine to drive. Yeah. So that's kind of what to expect for a C-section birth. Yeah.
Yeah,
I
great. Yeah. So, I mean, just to recap really quick, reasons for a C section, a planned C section, are maybe it's an elective C section because it's a repeat. You've had previous C sections, and so now you are going to have another baby, and so you're repeating the C section. A breech birth where the babies head up, multiples like twins or
yeah.
triplets, an indicated repeat, whether you have a prior classical cesarean or a prior uterine rupture. So you have to have a C section at that point. History of fibroids being removed, placenta previa, or like we talked about, if you're just electing to have a primary C section for any
Right.
reason.
Right. And most of the time we do those around 39 to 40 weeks, but sometimes for various reasons, they can happen a little bit earlier. As for the procedure itself, I definitely recommend you ask during your prenatal care how the cesarean approach is approached at your hospital. Things that you want that may be important to you, like music, who can be in the room, do they have a clear drape, those kind of things. The recovery is going to vary once you have a C section. Most women do really fine.
Yeah.
I think a lot of folks worry about the recovery, but most people do absolutely fine after a C section. And I think you should anticipate that it should not be too difficult to recover.
Yeah. Okay. So that's it. Um, that is our episode on C sections, on planned C sections. Do us a favor and share this podcast with a friend. Sharing is caring.
Yeah. And it helps us to reach and serve more people. Also, if you listen to this or after you listen to this and you had a plan, if you have a planned C-section birth, message us and let us know about your experience. How did it go? Were there things that we didn't cover that you didn't expect? Yeah, let us know.
Yeah, and if you have suggestions for other topics too, please feel free to message us. Tell your friends about our podcast and give us a review, give us a rating. But that's all we have for today. We hope you come back for another episode of Mama Doc Baby Doc. Bye.
Bye.